looking at heart failure, and the floor plan of the talk is introduction, definitions, epidemiology, etiology, pathophysiology, clinical features, diagnosis, prognosis, risk scoring, treatment, and prevention. Out of that, we have already covered in the last class introduction, definitions, epidemiology, and etiology. Partly pathophysiology we started. For the benefit of the newcomer, the previous video and the PDF are available in the group. So if that won't be available to her because she just joined the group. So you can share with her the previous video and the PDF. Always I have the habit of giving the PDF and video so that you will have a chance to have a look at that. Now let's go into the pathophysiology of heart failure. Why it is so important as a clinician to have the pathophysiology? Because it is the pathophysiological basis of therapeutics. The treatment of heart failure is dependent upon the pathophysiology. So what we have to do, we should learn the pathophysiology thoroughly. Then only we will be able to treat the patient properly. The developments in the understanding of the pathophysiology of heart failure have been essential for recent therapeutic advances. That's what I'm saying. So the therapy of heart failure is obviously based on the pathophysiology. After MI, after heart failure also, plasma concentrations of norepinephrine is the prognostic value in the early phase after MI. Nobody measures norepinephrine in your clinical setting after MI. If you do not do it, you will miss the prognosis. Keep it a point in your mind. After MI and heart failure, norepinephrine measurements have to be done. Natriuretic peptides are also known and shown to predict the outcome of myocardial infarction and heart failure. This is called the leukocyte count of the heart failure. Just like the leukocyte count is the important thing for infection, for heart failure and myocardial infarction, leukocyte count has got a lot of importance. The cardiac output is a product of stroke volume into heart failure. What happens in heart failure? The stroke volume is less. Compensatory heart rate tries to increase. That is why it is called tachycardia will be there. Cardiac output is expressed in liters per minute. Normal cardiac output is 5 liters per minute. Stroke volume is around 70 ml and 70 is the heart rate. 70 into 74,900 or 5 liters is the approximate cardiac output. There is what is called preload and afterload and contractility. These three determine the stroke volume. Preload is the amount of blood present and the load added to the heart before it starts contracting. When I say heart, it is the left ventricle mainly. And afterload is the load which the left ventricle has to overcome while it is contracting and pushing the blood forward. Contractility, of course, is the inherent property of the cardiac muscle, cardiac sensation. So, if I want to treat heart failure, I must manipulate the preload, afterload, and also contractility. There are drugs which reduce the preload or increase the preload. Likewise, drugs which increase or decrease the afterload, drugs which increase or decrease the contractility, depending on the given scenario. That's why these three aspects are important. Okay, now let's look at the next slide. Contractility is the intrinsic ability. Contractility is the intrinsic ability of the cardiac muscle to develop a force for a given muscle length. This is called ionotropism. There are ionotropic agents which increase the force and rate of contraction. Particularly, the ionotropics are the ones which increase the force of contraction. If rate of contraction is influenced, it is called chronotropic drug. Chronotropic and ionotropic. Chronotropic increases the rate, ionotropic increases the force of contraction. Preload is the muscle stretch or muscle length prior to contractility. It is dependent upon the ventricular filling, that is the left ventricular and diastolic volume is a measure of the preload. In heart failure, we expect the left ventricular and diastolic volume to be high because of the high preload. This is in turn dependent upon left ventricular diastolic pressure and left atrial pressure. So, what are the measurements of preload? How do I measure the preload? By looking at the LV and diastolic volume in the echo and the end diastolic pressure in the echo and left atrial pressure. These three measures, that is LV and LVEDV and LV diastolic pressure and LA pressure, tell me the preload. The most important determining factor of the preload is venous return, either systemic venous return or the pulmonary venous return. Pulmonary venous return into the left side, systemic venous return from cavas, inferior cavas, superior vena cava and inferior vena cava to the right atrium. Then the afterload. Afterload is the tension or the arterial pressure against which the ventricle must contract. That is, the force required by the ventricle will be more if the afterload is more to be overcome. For example, in hypertension, the arterial pressure will be higher. Left ventricle has to contract against a very high arterial pressure, and that increases the afterload. And this is determined by the aortic pressure, which is in turn dependent upon the peripheral arterial resistance. So, one measure of the afterload will be aortic pressure. What is the central aortic pressure as obtained in the echocardiogram? Or you can measure the peripheral arterial resistance also by various devices today. Imagine a woman carrying a pot of water on her head. If the woman is carrying the pot of water on the head and walking, already she is preloaded before the walk. Another woman is there, she is not carrying any bucket of water or head water pot on the head, but she is asked to walk on a gradient. That is the afterload. So, if the woman is walking on a gradient, uphill road with a pot of water on the head, both the preload and the afterload both are increased. This is easy to understand. Okay. Now, LV ejection fraction, all of you must know. What is ejection fraction? Ejection fraction is the LV and diastolic volume minus LV and systolic volume. What is the volume of blood at the end of diastole minus the volume of blood at the end of systole? That means that difference of blood is ejected into the aorta. LV and diastolic volume minus LV and systolic volume is the amount ejected. How much is ejected depends upon how much was available to start with. That is the denominator is the LV and diastolic volume. That is the formula. Now, for example, the calculation 140 ml is available at the end of diastole. At the end of systole, 70 ml is available. So, 70 ml is ejected out of how much? 140 to start with. So, the ejection fraction is 70 by 100 multiplied 70 by 140 multiplied by 100, which is equal to 50%. Now, I give you a small sum. End diastolic volume 180 and the end systolic volume is 80. What is the ejection fraction? End diastolic volume is 180 and systolic volume is 80. What is the ejection fraction? 100 minus 180 minus 80 is equal to 100. That divided by 180, 100 divided by 180 into 100 will be the ejection fraction. Ejection fraction normally is between 50 to 70%. If it is less than 50%, we can consider that is a reduced ejection fraction, heart failure. Sometimes ejection fraction can go up to 90% with exercise. Suppose a person is in say, vigorous exercise, stage 3 or 4 of treadmill, you can expect almost all the blood in the ventricle is ejected out to meet the demand of the exercise. So when does the ejection fraction go up? It goes up due to exercise, high fever, and also it goes because of hyperdynamic circulatory states in case of thyrotoxicosis and all others. This is the ejection fraction. So what are the things we learned? Preload, afterload. How to measure the preload? And diastolic volume and diastolic pressure, left atrial pressure. How to measure the afterload? At arterial pressure, peripheral arterial resistance. How to measure the ejection fraction? And this is the formula. LV diastolic volume and diastolic volume minus LV systolic volume divided by LV diastolic volume. Normally, the ejection fraction must be between 50 to 70%. Anything less than 50% we call as reduced systolic function or systolic heart failure. There could be heart failure without the ejection fraction being reduced, and that heart failure is called the preserved ejection fraction heart failure. Preserved ejection fraction heart failure means ejection fraction is not reduced. That means systolic function is not compromised, but the diastolic function alone is compromised. That is also called the diastolic dysfunction. Okay, mechanisms of heart failure. Why the heart needs to fail? For a general public, if you say there is heart failure, he thinks heart standstill, heart systolic arrest. This is not what we mean. Heart failure here means heart is unable to meet the demand of the body, but still it is functioning. Not that the heart stopped. It is not something like a systolic arrest. That is generally, if somebody, if heart failure is, his heart failed, that means no more pumping. Not like that. Mechanism of heart failure, restricted feeling. That is, heart is not able to fill with the blood. Why? Mitral stenosis, restrictive type of cardiomyopathy, constrictive pericarditis. So the filling is impaired, so much so there is no blood to eject properly. Number two, the pressure load on the ventricle is higher, that is the afterload is increased, as in case of aortic stenosis, pulmonic stenosis, hypertension, common cause of increased afterload, and then coarctational IO. The moment I see a patient, is there a chance the patient has got increased afterload or pressure overload? Is there a chance of decreased filling? I can know by these diseases. Or increased volume load, as in case of in the ventricle, regurgitant jets produce increased volume, that is dilatation of the ventricle, mitral regurgitation, aortic regurgitation, ventricular septal defect, tricuspid regurgitation, and pulmonic regurgitation. Or the heart is not able to contract properly because it's not receiving enough blood supply. Myocardial contraction is decreased either due to coronary artery disease or dilated cardiomyopathy or myocarditis. And finally, heart rhythm is abnormal. The plumbing part is okay, but the electrician part of the heart is not properly done. When there is a cardiac heart attack, then there is a plumbing problem because the blood supply is not there. When arrhythmia means electrical problem, that means electrical activity is not proper. That's why there is severe bradyartachy, atrial fibrillation, or heart. So these are the 5 mechanisms by which heart can fail. 1. Restricted filling due to restrictive diseases and increased afterload because of hypertension, ASP, coarctation, increased volume overload because of regurgitant phenomena or the ventricular septal defect. Myocardial contractility itself is reduced as in case of CAD, dilated cardiomyopathy and myocarditis, or in case of electrical problem of the heart like arrhythmia, severe bradycardia, tachycardia, atrial fibrillation, and heart block. This is the Frank-Starling curve, the standard expression of right atrial pressure or end diastolic volume. Right atrial pressure corresponds to the end diastolic volume. And as you can see, this is the stroke volume or the cardiac output. Normally, what will happen as the right atrial pressure increases, end diastolic volume increases, there should be an increase in the stroke volume. Because more blood is available, more should be ejected. But what happens after some degree, this will not work because it becomes flatter. Whatever may be the increase in the right atrial pressure, there won't be incremental increase in the stroke volume. That is more so whenever there is a negative inotropic effect. For example, when the heart inotropy, the force of contraction, is reduced due to various reasons, any increase in the right atrial pressure will not produce a commensurate increase in the stroke volume or cardiac output. Supposing I use a positive inotropic drug, for a given right atrial pressure, I can get a better stroke volume and better cardiac output. This is what the Frank-Starling curve tells. Okay. Now, sustained LVDF leads to LV diastolic failure Sustained LV dysfunction, not diastolic failure. LV dysfunction leads to hemodynamic, autonomic, neurohumoral, and immunological changes. What are the things that occur? Hemodynamic changes. Of course, autonomic changes will be there. There will be neurohumoral changes and immunological changes. Today, the world all over is thinking that heart failure is an inflammation, not infection. Heart failure is considered as an inflammation. And maybe in your generation, you see heart failure being managed as an anti inflammatory disease. Till now, we know it is a hemodynamic problem, autonomic problem, neurohumoral problem, immunological problem. Okay. Complex mechanisms in heart failure. Heart failure is not one disease, just like fever is not one disease. Heart failure is a multi-system syndrome. Abnormalities of the cardiac and skeletal muscle and abnormal renal function, stimulation of sympathetic nervous system, complex pattern of neurohumoral changes. So these are all the four things which will be affecting the multi-systems, complex pattern of neurohumoral changes, stimulation of the SNS, sympathetic nervous system, and abnormal renal function, abnormalities of the cardiac and skeletal muscle will be there. Ventricular remodeling, damage to the myocytes and extracellular matrix in the cardiac syncytium, changes in the size, shape, and function of the left ventricle. These produce ventricular remodeling after heart failure. And heart failure can also cause electrical instability, causing heart failure related arrhythmias and a systemic process with sequelae in other organs. That is why it is a multi-system syndrome. Okay. Pathophysiology of heart failure. Okay. Decreased cardiac output results in when can I expect the cardiac output to be reduced? When the end diastolic pressure is increased, or when there is left ventricular hypertrophy, or when left ventricular dilatation. Left ventricle is hypertrophic, left ventricle is dilated, or end diastolic pressure is high, so the heart is not able to pump forward. Pulmonary capillary wedge pressure is increased, that means right atrial pressure is increased, the back pressure in the pulmons is felt in the lungs, pulmonary capillary wedge pressure is increased, that leads to development of pulmonary edema. So whenever there is cardiac output is decreased, what will happen? When the output is not there, the diastolic blood remains in the heart. Blood stasis occurs in the heart. More amount of blood stays in the heart rather than ejected out. That increases the end diastolic pressure and produces left ventricular dilatation, left ventricular hypertrophy. Because of the back pressure, atrial pressure is increased and the atria are connected to the pulmons, and that's why pulmonary capillary wedge pressure, that is pulmonary capillary pressure is increased. Pulmonary capillary wedge pressure means pulmonary capillaries are incompetent to hold the fluid. The fluid is secreted forcefully into the lungs, and that produces pulmonary edema. Activation of neurohormonal mechanisms. Renin-angiotensin-aldosterone system, RAS, is the fundamental thing that we need to understand, and sympathetic nervous system, SNS, and other circulating and paracardial effects like the BNP and other things we have to see. There is a counter-regulatory system. That means angiotensin-aldosterone system is favorable initially, but it is detrimental in the long run. Sympathetic nervous system also is a favorable response to start with. Later on, it becomes a hindering response. The counter-regulatory system is natriuretic peptides, A and ANP, BNP, pro-BNP, which we are going to consider. Now we need to understand this particular mechanism very thoroughly. Angiotensinogen is from the liver. That is converted from the angiotensinogen is converted into angiotensin by the action of the renin extraglommerular apparatus renin, and that one angiotensin 1 is converted into angiotensin 2 by the ACE in the lungs. There are 2-3 ACE pathways which you should know. I will show you those pathways. Angiotensinogen is a globular protein. It is not like a chain. It is like a wound up and like a ball, and that has to be made into a decapeptide 10 amino acid sequence, which is angiotensin 1, which will 2 amino acids will be cut off further, becomes an octapeptide, which is angiotensin 2. The important enzymes are renin and ACE in the lung. Also, ACE is present in the renal parenchymal epithelium also, ACE is present. If at all there is the most powerful angiotensin or vessel tension increasing agent in the world, it is angiotensin. Angiotensin 2 has got three receptor sites to act. Angiotensin 1 receptors, angiotensin 2 receptors, angiotensin 4 receptors. In human beings, angiotensin 3 receptors are not performed and are under study. We will see in some more slides about 3 also. 81, 82 and query 84. 81 is harmful, 82 is protective and beneficial, 84 role not. In addition, angiotensin also triggers the secretion of aldosterone from the adrenal cortex. So angiotensin 2, through the aldosterone it is dangerous, through the 81 it is dangerous. Through the 82 it is beneficial. Suppose you block the 81 effect, by using angiotensin receptor blockers, what will happen? The angiotensin will be available to act on the 82. Naturally, it becomes beneficial. The harmful effects are prevented, and the angiotensin now is not allowed to go and attack the 81 receptor, so it's more available for the 82 receptor, which will be favorable. Okay. Now, 82 is the major effector hormone in the entire system, both for hypertension, diabetes, and renal disease. 82 is the most important thing. Angiotensinogen, ATNG, is the angiotensinogen converted to 81, 1 to 10 amino acids. 81 by the action of ACE, angiotensin converting enzyme, is now converted into angiotensin 2, which is a octapeptide, 8 molecules, 8 peptide, 8 amino acids are there in this. Okay. And this tensinogen can become angiotensin 2 by other mechanisms like non-ACE pathways. That is why after some time ACE escape occurs. You give ACE inhibitor, supposed to inhibit it, but this is inhibited all right, but there is other mechanisms by which angiotensin 2 is formed. That is why ACE inhibitors are today. Earlier, if you ask ACE inhibitors or ARBs, which are better drugs, we used to say 15 years back, ACE inhibitors, the captopril, ramipril, enalapril, lisinopril, etc., are the better drugs than the sartans. Now we know that sartans, angiotensin receptor blockers, are better drugs than ACE for various reasons, which we also see. So, what will happen? Angiotensin 2, I told you, it is a powerful vasoconstrictor through 81. It also increases the sympathetic nervous system, stimulates, and it attacks the adrenal cortex and increases the aldosterone. Aldosterone retains water and sodium. Sympathetic system increases the heart rate, and it will, to some extent, it will be useful initially. Later on, the failing heart, more pumping of this sympathetic amines will result in further failure, and vasoconstriction increases the afterload. And because of all these things, heart failure becomes worse. Now, once the 81 is there, instead of it becoming 82, it can take ACU2 pathway. That means another angiotensin converting enzyme, which converts into 81, all right, 81, which is 179. This is 1 to 8 direct all amino acids. Here it is 1 to 7, 8 is missing, 9 has come. This is also octapeptide. And it can form like that, or this can be manipulated into ACE2, and this is favorable. Anything green you are seeing, it's favorable. Red is seeing, it is dangerous. Renin is the hormone here, ACE1 here, non-ACE pathways, ACE2, ACE3. This is not an active metabolite. That is, the angiotensin 2-18 is active, whereas angiotensin 1-279, although it is an octapeptide, it is not metabolically active. Okay. This, up to that, we studied last time. This we need to study in detail. Look at this, the liver, angiotensinogen, and then angiotensinogen to angiotensin 1 by the action of renin from juxtaglomerular apparatus. Why? When the renal perfusion is decreased, body senses the need to increase the blood volume. So secretes the renin. Renin acts on the angiotensinogen to become angiotensin 1, and this is cleaved by ACE, which is there in the lungs and also on the surface of the renal endothelium also. It is there. This ACE makes it available as angiotensin 2. Now, this is not a simple drug, simple hormone. This angiotensin 2 is very powerful. What it does, it acts on the SNS to increase the sympathetic activity. It acts on the tubular mechanism of sodium and chloride. It reabsorbs the sodium, reabsorbs the chloride, excretes the potassium, and reabsorbs the water. When I have a dotted line here, it is passive reabsorption. These full lines are actively it pushes the sodium into the body and pushes the potassium out. That is why when you are using drugs which block this particular angiotensin 2, that is AC inhibitors, this action is reversed. Then potassium hyperkalemia you have to look for. Here, hypokalemia, hypernatremia, water retention, increase in the blood volume, sympathetic activity. On the adrenal cortex, it produces aldosterone secretion, and that increases the water content as well as sodium through the renal mechanism. And arterial vasoconstriction increases the blood pressure. It acts on the arterioles to produce increases the blood pressure. Not only that, it acts on the posterior pituitary to increase the ADH secretion. ADH secretion is antidiuretic hormone. It acts on the collecting duct through the aquaporin channels, which we have seen earlier, and that produces passive water reabsorption, which means there will be less of urine in the urine formation and more of fluid conservation, increases the blood volume. All these are offset once the blood volume is normalized. There is a negative feedback. Renin is offset. Renin becomes lesser. The entire chain becomes reversed. So what are the areas I have to look for? The renin here, renin blockers, angiotensin 1 to 2, ACE blockers, angiotensin's effect on the tubule, on the sympathetic activity, on the adrenal cortex, aldosterone, on the arterial blood pressure, on the ADH. All are important for us to understand the pathological effects of RAAS. Earlier it was called RAS. Now it is renin angiotensin aldosterone system. That is also a part of the story. The central molecule is angiotensin 2. Okay. AT2 and aldosterone havoc. What sort of havoc they produce? AT2 is the key hormone. Aldosterone is a supporting thief which increases the prop. The main thief is AT2. Increased AT2, vasoconstriction, myocyte hypertrophy, myofibril fibril fibrosis, increased aldosterone release, activation of norepinephrine, activation of endothelin 1. Endothelin has got three types, endothelin 1, 2 and 3. Out of endothelin 1 is again detrimental. 2 and 3 are positive. So there is a endothelial dysfunction occurs, decrease in the nitric oxide, increase in the endothelial inflammation. So what are the mechanisms occurring? AT2 increased vasoconstriction, myocyte hypertrophy, myofibril fibrosis, increased aldosterone release, sodium and water retention, increase in the blood volume, fluid logging, patient becomes edematous, activation of the norepinephrine, so sympathetic activity is increased, ET1 is increased, endothelial dysfunction occurs. Endothelium smiles when the nitric oxide is there. You would have learned in chemistry laughing gas, nitrous oxide, and that nitrous oxide gets converted into nitric oxide. When there is good amount of nitric oxide in the endothelium will be smiling. But if the nitric oxide is less, endothelium will be weeping. That weeping is the inflammation. Endothelial inflammation occurs. Aldosterone excess, sodium and water retention occurs because of the aldosterone. It is a salt retaining hormone. Along with the salt, water also is retained. Potassium is pushed out. Hypokalemia, volume overload, pulmonary edema, leg edema, ankle edema, peripheral edema, myocardial apoptosis, myocardial fibrosis, increased afterload because of fluid retention, increased after. So one is increasing the vasoconstriction and increasing the afterload this way, and also it is increasing the blood volume and increasing the afterload the other way. Both ways the heart has to overcome lot of load to function. Now, harmful effects of angiotensin: heart, coronaries, kidneys, adrenals, coagulation. Angiotensin acts on the coagulation also. On the heart, myocardial hypertrophy, interstitial fibrosis, inotropic effects. On the coronaries, endothelial dysfunction, decreased nitric oxide, coronary vasoconstriction, oxidative stress is increased, inflammatory molecules are secreted, erythema formation occurs. On the kidneys, intraglomerular pressure is increased, proteinuria occurs, increased sodium reabsorption, glomerular growth and fibrosis, growth factors and fibrosis are promoted, increase in the ADH secretion from the posterior pituitary. Adrenals, increased aldosterone, augments the sympathetic nervous system. Because the adrenals have also supply the noradrenaline and adrenaline on the medulla oblongata and produces the SNS activation. That is sympathetic nervous system. Coagulation, increased fibrinogen, increased PAI1, that is plasmin cutting. This one is reduced, and platelet aggregation also is plasmin activator inhibitor. PAI is plasmin activator inhibitor, and the PAI1 is essential to prevent the clot, and that is all increased here. That is why there will be procoagulatory in nature. Okay, aldosterone basically has action on three things. Earlier we have seen the action of the angiotensin. Here we are seeing the action of the aldosterone. Aldosterone acts on kidney, heart, and blood vessels. On the kidney, glomerular sclerosis, interstitial fibrosis, proteinuria, renal failure. On the heart, LVH, cardiac fibrosis, LV dysfunction, heart failure. On the endothelium, endothelial dysfunction, endothelial inflammation, and oxidative stress. So both these hormones together, angiotensin 2 and aldosterone, produce all the clinical features of heart failure, and both these hormones have to be kept under control in the treatment of heart failure. Okay, we have a drug which is now a direct aldosterone receptor antagonist, mineralocorticoid receptor antagonist, eplerenone, and the brand name available is called epleristat. Whereas you have other spironolactone, other drugs which interfere with the aldosterone mechanism, but they are not receptor antagonists. This is the direct receptor antagonist. Now, where can I block this RAA? ROS blockade. Okay, at the level of renin, I can block by using what is called the Elucidation, or I can prevent the conversion of AT1 to AT2 by inhibiting the ACI enzyme. Or once AT2 is formed, I can block its negative effect by ARBs, or once also block the AT1 effects on the aldosterone by using mineralocorticoid receptor antagonists. Now look at here, the treatment is Elucidation for renin, ACE inhibitors for AT1 to AT2, ARBs for AT2 action on the AT1 receptors, and aldosterone antagonists like mineralocorticoid receptor antagonists. Now, what will happen if I use ACE inhibitors and the bradykinin will increase? This bradykinin is important for vasoprotection, but bradykinin retains some fluid in the lungs. This is called the ACE cough. People who are on ACE inhibitors, they will have persistent cough. If it is dry cough, if a patient who has started on ACE inhibitors, within a week or 10 days, he develops dry cough, which is unremitting with anything, don't treat with antibiotics, don't treat with cough fixer, try to reduce the dose of ACE inhibitor or change it to ARB, because it is a ACE cough. It is a non-iatrogenic cough produced. Okay. Then AT2, when I block it, AT1 receptors are blocked. AT2 is favorable. AT2 and AT4 are available. They produce vasoprotection. Okay. Now, angiotensin 1, angiotensin 2, AT1 receptors, harmful, AT2 receptors, positive. Now I use an ACE inhibitor, block this conversion. Angiotensin 1 is not converted into angiotensin 2, but this ACE inhibitor also blocks bradykinin conversion into inactive peptide. So much so bradykinin is left, and that bradykinin is in the lungs, and that bradykinin produces produces the ACE cough. If somebody asks you what is the cough of ACE inhibitor, if you use what is increase in levels of bradykinin, because ACE inhibitor also not only interferes with this conversion, it also interferes with bradykinin into inactive peptide. That is also blocked. Bradykinin levels are increased, and that produces ACE cough. Now, see this carefully. Angiotensinogen to angiotensin 1, 12 peptides have become 10 peptide. The enzyme required is the renin there, and then ACE enzyme is required to convert into angiotensin 2, and that angiotensin 2 acts on the AR receptor 1, angiotensin receptor 1, which is the most dangerous receptor for its action. If this is blocked by your ARBs, naturally angiotensin 2 will go to the other receptor, AR2 receptors, which are beneficial. What are the problems if the AR1 receptor are attacked? 1. Pathological hypertrophy and fibrosis of the heart, vasoconstriction, oxidative stress and remodeling on the vasculature, aldosterone release and sodium reabsorption, water reabsorption, the kidneys, norepinephrine release from the central nervous system and other sympathomimetic amyloids. Angiotensin to angiotensin 1, renin blockers are there. Angiotensin 1 to angiotensin 2, ACE is the enzyme, ACE inhibitors are there. The side effect is increase in the bradykinin. Then, not only ACE, there are some other enzymes like chymase, CAGE, cathepsin G, which have a potency to convert angiotensin 1 to angiotensin 2. You may think that I have blocked this pathway, but this door is blocked, but there is a side door. That side door is the kinase pathway, or CAG pathway, or cathepsin pathway. That is why ACE inhibitors after some time fail to respond, give the response required, because these pathways get activated. Okay. Or angiotensin 1, if it is blocked, this angiotensin 1, what will happen? You have blocked it to go down to become angiotensin 2, it becomes angiotensin 1,9. And there is another type of ACE enzyme there that becomes 1,7. And angiotensin 2 also becomes 1,7. This is a favorable molecule. That's why when you block this pathway, angiotensin takes this pathway, which is a favorable thing. What is that? You can see this acts on the MAS receptors. MAS receptors are all vascular effects or endothelial function is increased, vasodilatation is produced, vascular smooth muscle proliferation is decreased, vascular smooth muscle migration is decreased, anti-inflammatory property, anti-thrombotic property, cardiac effects, anti-hypertrophic, anti-fibrotic, anti-inflammatory, all are positive. The MAS receptor actions are all positive. Which acts on the MAS receptor? Angiotensin 1,7. How is it formed? From 1,9. How is 1,9 formed? Angiotensin 1. But this is not the normal route. Normal route is angiotensin 1 to go to angiotensin 2. Now I blocked with the ACE enzyme. Angiotensin 1 has got no other go but to become angiotensin 1,9, and that 1,9 becomes 1,7. Then that acts on the MAS receptors, which are very favorable. Okay. Angiotensin 2, if it is there, and if it is not blocked by ARBs, and it acts on the angiotensin 1, which is negative effect, endothelial function is decreased, vasoconstriction, vascular smooth muscle proliferation, vascular smooth muscle migration increase, pro-inflammatory, pro-thrombotic, all negative cardiac effects are there. Just the opposite of MAS receptors. Whereas, suppose I block this 81 also, using the ARB, then this angiotensin 2 cannot act on this side. It can go on to the ATR side, which again has a favorable effect like that. So angiotensin 2 becomes angiotensin 3 by another ACE2 enzyme. This acts on the 83 receptors and 84 receptors. These are prothrombotic in nature. These are less well studied in humans. Now, we have drugs which increase the function of the MAS receptors, or which increase the angiotensin 1,7. We have drugs which block this pathway, all these sartans, so much so this is available for the favorable pathway and not the unfavorable 81 receptor. It acts on the 82 receptor. Now you can imagine how I can treat a heart failure or reduce the RAS stress. I can treat here by renin inhibitors. I can treat here by giving ACE inhibitors. Mind you, the cough, mind you, the good effects to the MAS receptors. And also I can treat. Once angiotensin 2 is formed, the negative effects I can prevent by using the ARB blockers, and the positive effects will be enhanced. These have got limited role in human suspension. Now, angiotensin 2, renin, you see the decapeptide, 8 amino acids are there. Their names are also written. ACE enzyme, 1,8 standard pathway goes to ATR receptor 1, ATR2 receptors. Whereas, and if the 1,8 is converted by ACE2 into 1,7, it acts on the MAS receptors. MAS receptors, MAS are, and then 82 are favorable. 81 is not favorable. Okay, when you have blocked this, it will go into this pathway, NEP pathway. There it is the 1,7, this one. And this is again the NEP pathway. Inactive 82 fragments also are produced by this. So there are several types of 82s. 1,8 is there, 1,10 is there, 1,7 is there, 1,9 is there. Depending on which molecule is an excess, whether it is a favorable effect or an unfavorable effect, we will get the answer. Now, in heart failure, we have seen extensively about the RAS. RAS includes aldosterone also. In addition, there is the SNS, sympathetic nervous system. There is also NPS, so neuropeptide system. NPS is the neuropeptide system. Okay, now we have a drug, sacubitril, preserves the protective benefits of NPS by inhibiting neprilysin, reducing the degradation of NPS. These neuroprotective enzymes are produced, the B-natriuretic peptide and A-natriuretic peptide. They are degraded by an enzyme called neprilysin. And we have a drug to interfere with the neprilysin, sacubitril. If you use sacubitril, you can increase the levels of NPS. That is the B-natriuretic peptide and A-natriuretic peptide, which are favorable. And that leads to vasodilatation, less fibrosis, natriuresis, and diuresis. Okay, that is one other mechanism of treating heart failure. Earlier, we have seen so many mechanisms how to treat heart failure: anti-renin, ACE inhibitor blocker, angiotensin blockers, MAS receptor activity increasers. All these things are available. In addition, I also got a NPS stabilizers. These are called the sacubitril. And if I use valsartan, what it will do? All sartans act as the 81 receptor antagonist. So much so RAS blockade is done, so the negative effects are reduced, and 82 receptor activity is again favorable, and that is how I treat the heart failure. Now, treatment of heart failure is reducing the RAS activity, increasing the NPS activity, and reducing the sympathetic nervous activity. There are three mechanisms by which are neurohumoral mechanisms of heart failure. The RAS system, which includes angiotensin 2 with its ATR1 and ATR2, negative and positive actions, aldosterone role, and the enzymes to block. And the SNS is the sympathetic nervous system, which again has to be suppressed. By reducing the heart rate, we will be able to favor the heart failure. Likewise, the NPS system has to be stabilized by using sacubitril, which interferes with the anti-neprilysin drug, which inhibits the neprilysin. Now, again, angiotensin to this renin, anti-renin inhibitor, angiotensin 1, ACE inhibitor, angiotensin 2, ARB, aldosterone, mineralocorticoid receptor antagonist. We can have a block here also, or we can have a block here. Once this is blocked, the favorable activity on 82 is increased, and cardiac protection increases, cardiotoxicity is reduced, and finally, the bradykinin is more. That is because they have blocked the angiotensin 1, the ACE inhibitor. Naturally, this bradykinin will take other kinase pathways, and this bradykinin to kinin degradation products. Instead of that, the excess bradykinin is presented here, which actually bradykinin is a favorable hormone, which increases the endothelial nitric oxide, endothelial the PGI, and epidermal growth factors, and the tissue plasminogen activator. All these are favorable, and vasodilatation, anti-growth, anti-proliferation, anti-fibrosis, anti-apoptosis, cardioprotection. So there are several ways which I can do. Now, coming to the SNS. sympathetic nervous system. Cardiac output decreases, decrease in the cardiac output activates the parareceptor. What is the role? Why the sympathetic nervous system to be activated? Cardiac output is not coming. That means that not enough blood is coming into the carotid artery. There, the carotid parareceptors are there. They sense this fellow is not able to press the heart powerfully and eject the blood into the carotid parareceptors. Carotid parareceptors will send a signal to the brain and also all the sympathetic chain of events and to increase the sympathetic act. The effect is circulating epinephrine and norepinephrine are increased. Epinephrine, norepinephrine, they increase the heart rate, they increase the blood pressure, they increase the myocardial demand and toxic effects on the myocardium and cell death can occur, down-regulation of the beta 1 receptors in the heart, decrease in the parasympathetic activity, all are detrimental in the long run. Now, see the effect of norepinephrine in heart failure. This is a Kaplan-Meier curve, survival curves, 0 months to 60 months. If we follow, if you have an noradrenaline level of more than 5.32 nanomoles per liter, that is the red line, you see this is the mortality, cumulative mortality percentage. How many people are available after 46 months, 48 months? 90% of fellows died. Only 10% are available if the sympathetic activity is more. That means norepinephrine levels are low. Versus you control the norepinephrine to manageable levels of less than 3.55 nanomoles. At the end of 48 years, 40% only died, the remaining 60% are available. Means what? I have to suppress the norepinephrine. I should know what is the norepinephrine level in heart failure. I never know whether any one of you are altering norepinephrine levels in a patient of heart failure. If you are not doing, start doing it. If it is on the higher side, you have to bring it down to give a positive health benefit and then survival benefit. If the norepinephrine levels are kept low, the survival is much better. Okay, you can see very widely. If it is in between, the survival is in between. If the norepinephrine levels are unchecked and they are high, you are risking the patient's longevity, and majority of them will be no more for you to follow up after 2 or 3 years. So these are the effects of RAS, effects of aldosterone, ACE inhibitor, 81, 82, and then the bradykinin, and then MES receptors, all we have talked. SNS also we have talked. Then the paracrine effects are there. Endocrine and paracrine. Paracrine secondary, endocrine responses. Production of the endothelin. This is another very important vasoconstrictor, ET1R. It can act on 3 receptors. ET1 receptor is detrimental, 2 and 3 are favorable. A potent vasoconstrictor through ET1 receptor. And second thing is increase in the vasopressin, ADH from the pituitary. ADH is antidiuretic hormone, that is fluid is retained, sodium is retained, and it is itself as a vasopressor, its name itself is vasopressin. It produces vasoconstriction. And then excess cytokines like tumor necrosis factor alpha, and then the interleukin 1, interleukin 6, myocyte apoptosis, and then cardiac cachexia. What is apoptosis? Any idea what is apoptosis? Programmed cell death. Apoptosis and necrosis. What is the difference between the two? Apoptosis means functional death. Necrosis is anatomic, physical death. Cell is no more living. Necrosis. Cell is living all right, but it's functionally it is dead. Like, it's not functionally active. That's the difference between apoptosis and necrosis. Increase in the circulating steroids and growth hormone. These what are the paracrine effects of heart failure? You may have an essay question, discuss the neurohumoral changes in heart failure. Then all these things will come. RAS system, aldosterone, MES receptors, bradykinin, then this SNS, then the paracrine effects which I am talking, all these come under that. What are the four paracrine effects? Excess production of endothelin. Through ET1 it is dangerous. Increase in the vasopressin ADH through pituitary, vasoconstriction and water retention. Excess of cytokines due to tumor necrosis factor alpha, interleukin 1 and 2 are mediators which can produce damage, myocyte apoptosis and cardiac Cachexia is there in circulating steroids also. The growth hormone also are increased. So these are the various things that can occur. What are the counter-regulatory systems? Is the body keeping quiet when so much havoc is going on, or is it doing something for the heart failure? It will do. These are called the counter-regulatory. Counter-regulatory hormones are okay. So is the body doing something? And so much
Is the body doing
problem is being
something?
created
And so
by
much
this.
problem is being created by this.
The counter-regulatory system increased LV.
The counter-regulatory system increased LV diastolic,
Increased LV diastolic pressure and left atrial pressure. That's what is occurring, isn't it? Whenever the heart is not able to pump blood and diastolic pressure increases, left atrial pressure increases. That immediately triggers what are called the natriuretic peptides. So LV and LA wall stretch occurs. LA and LV wall stretched, natriuretic peptides will come into picture. Natriuretic peptide hormones are two types. One is called the atrial natriuretic peptide. The other one is called the P-natriuretic peptide. A natriuretic peptide cleaved part is called the NT-pro-ANP, likewise NT-pro-BNP. Okay. NT-pro-BNP and pro-BNP, NT-pro-ANP and ANP. The active peptides of BNP offset the ROS and sympathetic nervous system. They will have to attack both the RAS and the sympathetic nervous system by increasing the vasodilatation, by increasing the natriuresis and uresis, and sending the sodium along with that water out. And they will also produce adrenomedulin. There's a hormone called adrenomedulin, which will favorably have an effect on the heart rate. So these are the counter-regulatory hormones. When you are asked to write about the the pathophysiology of heart failure, you have to write also the counter-regulatory hormones also. What are the counter-regulatory hormones? What are the counter-regulatory hormones? We have to see. That is the heart, atria and the ventricles. So due to increase in the LV and diastolic pressure and left atrial and right atrial pressure, there is a stretch of the atrial wall that produces atrial natriuretic peptide, N-terminal atrial natriuretic peptide, which is nothing but atrial and natriuretic peptide only, with the N-terminal part separated from the main chain. And brain natriuretic peptide is secreted from the ventricles. It was originally thought it is secreted from the brain. That's why it's called brain natriuretic peptide. But now we know it is a product of the ventricles. Stretch or increase in the cardiac chamber volume leads to release of the natriuretic peptide. A from the natriuretic peptide atrial. Second one is B from the ventricles, which is the brain natriuretic peptide. What is the net effect? Net effect is vasodilatation, increase in the urinary sodium excretion, favorable for the heart. They attack the counter regulate the effects of the RAS and sympathetic nervous system. Now, what is heart failure? Heart failure is nothing but a balance between RAS and BNP. This is a new concept. Earlier, people were thinking heart failure is because of the heart failure is because of the RAS only or sympathetic nervous system only. Now we very much know that it is a balance of RAS and the BNP. What is BNP? BNP 108 amino acid. This is the pro molecule, pro BNP 108. Then anti-pro BNP, N-terminal pro BNP is 32 amino acids. BNP is remaining 32 amino acids. 76 plus 32. 76 anti-pro BNP, 32 BNP. That is 1 to 76 amino acids is one part, 77th amino acids 208 is the another part. Why two things, anti-pro BNP and BNP, which one to measure? Clinician needs to know, isn't it? That I will show. So endothelium is not just a lining of the blood vessel. No more it is thought like that. So there should be some lining. So then some carpet-like thing is produced on the endothelium. And endothelium is only, it covers the inner parts from attack of the blood and other blood contents. That was the teaching. Now, the largest endocrine gland of the body is endothelium. It is the largest endocrine gland because it is everywhere. What does it produce? Vasodilators, sodium nitric oxide, bradykinin, prostacyclins, endothelial derived hot factors, serotonin, histamine, CNP, substance P. All are positive endothelial positive factors. Inhibitors of smooth muscle growth factors. Now, again, these are nitric oxide, prostacyclin, bradykinin, heparin, TGF alpha, and then the CNP. Okay. Inflammatory inhibitors, nitric oxide. These are the positive side of the endothelium. When the endothelium is dysfunctioning, when the endothelium is not well, when it gets a fever or cold or cough, we all become dysfunctional, isn't it? Like that, endothelium also becomes dysfunctional. Who will spoil the endothelium? I only will spoil the endothelium by lack of proper exercise, lack of proper, nutritious, wholesome food, and diabetes, hypertension, dyslipidemia, smoking, all these damage the endothelium. What will happen then? The endothelium loses its protective benefit, like vasodilation, like inhibition of smooth muscle growth, like anti-inflammation, all are lost. And that is and thrombolytic factors to prevent thrombosis also, endothelial good health. How to protect the endothelial health? By proper exercise, diet, control of the standard risk factors like obesity, diabetes, hypertension, dyslipidemia, smoking, stress, and all those things. So the vasoconstrictor also produced with endothelium. These are produced because endothelium is sleeping now. Endothelium is damaged. AT2, endothelium, thromboxane A2, aldosterone, and then the PEGH2, promoters of smooth muscle growth factors like PGDF, BFCG, so many factors, and promoters of inflammation, superoxide, and then the TNF alpha, and all adhesion molecules. ICAM, ECAM, VCAM, all these are adhesion molecules and thrombotic factors like PI. So it is up to you to keep the endothelium healthy or very unhealthy also. Endothelial health is human health. Today there is no other disease other than endothelial dysfunction. If you say diabetes, endothelial dysfunction. If you say polycystic ovary disease, endothelial dysfunction. If you say erectile dysfunction, endothelial dysfunction. If you say it is coronary artery stenosis, endothelial dysfunction. If you say brain stroke, it is endothelial dysfunction. This is called common ground hypothesis. The common ground hypothesis has shifted the entire focus on endothelial function, proper endothelial function. And we have no business to tamper the good endothelial function by bad habits and all these risk factors. Now, what will happen? If the endothelial target disease of endothelium antagonist, endothelium is a dangerous hormone. I told you this endothelium produces atherosclerosis, hypertension, angina pectoris, myocardial infarction, cardiomyopathy, heart failure, name any, and then pulmonary hypertension also. And the mechanism is vasoconstriction, coronary spasm, injury to the myocytes, injury to the and then the vascular proliferation, activation of macrophages. All these are detrimental. These target diseases can be prevented by endothelium antagonists. We never know that there is an endothelium which is an important hormone, which is important to be preserved and actions to be antagonized. We never had the drugs. Now you people have a wonderful opportunity to use all these centons. We are going to see in the next slide. Avocenton, 25 milligrams, 50 milligrams placebo. Supposing a person is not using the endothelium antagonist, what will be the death? So if you see here, at the end of 6 years, only 20% are surviving without endothelium antagonist. With endothelium antagonist, around the death is only 10%, and the remaining 88% are available for life. This is a beautiful survival benefit is demonstrated in that annotated study that endothelium antagonists are an important integral part of treatment of heart failure. Now, what did you get? A new drug also has come. The Avasentons, the other drugs which we see in the Next slide. Now, vasoactivity of endothelins. Endothelin 1, endothelin 2, endothelin 3. 1 ETAR receptor is harmful, and then the endothelin 2 is helpful. Endothelin 3 is mixed. Endothelium, heart, renal tubule, vascular smooth muscle. So ECE is endothelin converting enzyme. Just like the ACE, angiotensin converting enzyme, we have got a ECE. This ECE converts the 39 amino acid endothelin into an active ingredient called 21 amino acid ingredient. That can act on ET1 or ET2 or ET3 receptor, out of which endothelin 1 is harmful, 2 is helpful, and 3 is detrimental. Endothelin antagonist tyrosine, cetexenton, tejocenton, bosenton, avocenton are all the new drugs, endothelin antagonists, very popularly used in pulmonary hypertension, and it should be used in heart failure also. Now, some more of pathophysiology here. Bone marrow and spleen are the ones which produce the reticulated side and leukocyte that gets converted into a macrophage or a mast cell or a monocyte or a lymphocyte or a neutrophil. These are all the differentiated cells that occur. There are PAMPs and DAMPs. What is PAMP and what is DAMP? DAMP is damage associated molecular patterns. Damage associated molecular patterns, and then PAMPs are which are the induced the patterns molecular pathogen associated PAMPs. If there is a pathogen, PAMPs will come. No pathogen, DAMP will be there. These will trigger which particular cell to become more. And these we know are some of them are anti-inflammatory like macrophages and monocytes are anti-inflammatory. Some of them are pro-inflammatory. Depending upon the DAMP and PAM, the inflammation is triggered, and that results in profibrotic signaling, cytokine release, fibroblasts occurring, and DAMPs and PAMs act on the TLR receptors. TLR toll-like receptors are there. These will further perpetuate the action. Then what did I know from this slide? Now, heart failure is thought as an inflammatory disease. Because of the stress that induces myocardium, it produces DAMPs and uses the PAMPs, and through the bone marrow derived various cells triggers inflammation and fibrosis, which are further augmented through the TLR-like receptor. Cardiac myocyte, myocardial apoptosis occurs, and finally you have the cardiac fibrosis and cardiac remodeling also occurred. Cardiac remodeling also occurred. Now, you see here. The same slide continuing with more information about the various types of T cells. This is a native T cells. A naive T cell, mature dendrocytes are there. These naive T cells, either they can be T regulators or Th17 or Th2 or Th1, which are the mediators of interleukin 10, 17, 21, 22, all these inflammatory molecules. So what is happening now? Heart failure is slowly getting converted into not only a neurohumoral disease, it is also an inflammatory disease. Okay, there are the various studies which have been conducted in the recent past about the target, whether I can target any of the inflammatory molecules to prevent the heart failure progression and to treat the heart failure. So far, we do not have a direct evidence to use either pentoxifillin or etanercept or rosuvastatin or pentoxifillin combination or Cicalate or any one of the IV immunoglobulin to favor the heart failure. But I am sure days are not far off. Some new agents will come which will block the various targets of inflammation and produce a positive effect on the heart failure. Now, what are the other changes in the heart failure? Peripheral changes, anorexia, insulin resistance, tumor necrosis factor alpha, and the noradrenaline, but produces wasting, decrease in the perfusion, and weight, fatigue, abnormal metabolism. Atrial ventricular arrhythmias produce atrial fibrillation, structural changes, neurohumoral changes, ischemia, electrolyte abnormalities. Okay, and comorbidities cause deterioration, CKD, decrease in the EGFR, hypertension, diabetes, anemia, valvular disease, and myocardial infarction. These are the other changes other than the neurohormonal changes, other than the pro-BNP, NTP-pro-BNP, other than the inflammatory things that we have talked about. Ventricular remodeling is a new concept that when myocardial infarction occurs, reduces systolic function, increases LV and diastolic volume, increases wall stress, non-infarcted segment, regional hypertrophy, infarcted segment, infarct expansion, heart failure, and death. Neurohumoral activation, and this is called the remodeling. Ventricular remodeling after extensive myocardial infarction, remodeling occurs. Factors which affect remodeling are large infarct, anterior infarct, hypertension, persistent occlusion of the artery of the infarct area. And also, after extensive myocardial infarction, impaired cardiac contractility, neurohumoral activation leads to regional eccentric and concentric hypertrophy of the non-infarcted segment, regional thinning and dilatation of the infarcted artery. So what are we now looking at? We are looking at the parallel changes occurring in the heart, and this is called the cardiac remodeling. This is also part of the pathophysiology of heart failure. So the cardiac remodeling, you can see this is the normal cut section. Left ventricle is looking beautifully here. This is the right ventricle. This is the plane of the section here. And then there is infarcted muscle. And then because of remodeling, it thinned out and a dilated ventricle is produced. And this is a thinned out ventricle or ventricular aneurysm also can occur. So how to prevent these things? I don't want this type of ventricle to become this bad because of infarction. I want to prevent the cardiac remodeling. There are drugs like beta blockers, ACE inhibitors, and then other drugs which can decrease the cardiac remodeling. So cardiovascular continuum, AMI, acute myocardial infarction, LV systolic dysfunction, systolic heart failure, cardiometabolic risk factors, hypertension, coronary artery disease, chronic coronary artery disease, ischemia. This is a continuous cycle. Now, remodeling, stunning, and hibernation. This we will see in the next class. Important events that occur, you must know what is remodeling, what is stunning of the myocardium, what is hibernation of the myocardium. These are very important for you for management of heart failure and management of infarction. Immediately after the heart failure lectures, we will take up myocardial infarction so that the continuity will be maintained. Acute coronary syndromes, we will take up after this. This heart failure itself will be a 4-5 lectures. As you have seen, the pathophysiology itself is so deep and so overwhelmingly interesting to know that heart failure has to be treated in the right way using the pathophysiological basis. With this, what we will do, we will end the presentation here and then meet next week.